Good evening. I'm Janet Heischetter, and it's my honor to serve as the Executive Director for the Dystonia Medical Research Foundation, or the DMRF. The DMRF is committed to supporting research that will lead to better treatments and ultimately a cure for all forms of dystonia. The foundation also knows that the science can never move fast enough for those who are waiting for answers. So we are committed to providing programs of education, awareness, advocacy, and support for those who are affected and their families and friends. I want to give a quick shout out to the many support group leaders who registered for tonight's program. They're always wanting to learn more about how they can help and how they can be a resource to the people in their communities living with dystonia, and we appreciate all they do. Our topic tonight is one that everyone should be interested in: sleep. We're learning more and more about how important sleep is to overall good health. Getting a good night's sleep is not always easy, especially for those living with dystonia. Many in the dystonia community have expressed this as a concern, and we're pleased to present this program tonight. Our speaker is Dr. Danette Taylor. Dr. Taylor is a movement disorder neurologist with Henry Ford Healthcare Systems in West Bloomfield, Michigan. She received her medical degree from Michigan State University College of Osteopathic Medicine and did her training at Beaumont Hospital in Michigan. Dr. Taylor treats many people with movement disorders, including those with Parkinson's disease, tremor, and thankfully for us, dystonia. I will say she also makes a great effort to check in with the caregivers of her patients, recognizing the important role that caregivers have in our community. She's been in practice for more than 20 years, and I want to thank her for her many efforts in preparing the program for tonight. It's my pleasure now to turn the program over to Dr. Taylor. Dr. Taylor.
Good evening, everybody, and thank you to everyone who is on board this evening and listening in. And I hope that we will be able to answer some questions. So first and foremost, obviously, we're going to talk this evening about sleep and dystonia. Now, I'm not going to pretend that I have all of the answers. This is an important topic, and we will be talking initially about why do we sleep, what are some normal stages of sleep, how does dystonia impact our sleep, does it impact our sleep, and finally, what can be done about some common sleep issues. So again, not all the answers, but certainly maybe some of the answers we'll go through this evening. For those of you who have difficulty sleeping, perhaps you're going to want to make a recording of this and listen to it to help you fall asleep as the evening goes on. So, normal adult sleep, let's start with that. So how much do most adults, most grown-ups sleep? We talk about an average of 8 hours, and that's because that is the average for most of us. Many people feel that they can get away with a little bit less sleep than that, but if we actually look at the amount of sleep that people need, if there are no constraints around them and they're getting normal good night's sleep, right around 8 hours turns out to be that smack dab in the middle average. We talk about normal sleep latency. What is that? That's the amount of time it takes us to fall asleep. And so anything that is about 5 to 10 minutes is pretty normal. If you are routinely falling asleep in much less than 5 minutes, you're probably a little bit chronically sleep deprived. If it's taking you a great deal longer than that, then you may have a topic you may have a condition that we're going to spend a fair amount of time on, and that is insomnia. So we're going to talk more about normal sleep structure, but just to kind of give you a heads up or introduce it briefly, we talk about stage 1, stage 2, stages 3 and 4 sleep. The stages 3 and 4 sleep are the restorative sleep that we need, and then REM sleep is rapid eye movement or when we're dreaming. In Western culture, it's pretty societally acceptable to sleep and to nap as infants and young children and as elderly. And we kind of frown upon napping for typical quote-unquote grown-ups or adults, because we feel as though that should be time that we're spending doing productive type of activity, that may or may not be a good plan for you, and it may be that other cultures that have a more accepted view of napping really have the right idea. So there are a couple of factors that might influence how sleepy you are during the course of the day. The first one we call process S, or sleep-wake balance, and that's really kind of almost commonsensical, and that is the longer it's been since you've last slept, the sleepier you are. And you've all experienced that if you've had a really long day, you had to get up at 5 o'clock in the morning to catch a plane, and then you were, I took a long plane ride, and then you ended up someplace that the time zone was a little bit different, and you ended up staying up quite a bit later than you typically would. You know just how exhausted you really are and how much you really want to sleep. The other thing that we think about is process C, or circadian rhythm, which is really your body's clock, or kind of a cyclic variation of different hormones from our brain that helps our bodies become sleepy, helps our brains begin to wind down and go to sleep, and then when the time is right to wake up again. This is just graph form of that process S, or that drive to sleep. And if you look at the horizontal axis, where the words awake and asleep appear, the longer that is, that's the longer amount of time you've been awake. The vertical axis, going from low to high, is the pressure that you're feeling to actually fall asleep, and you can follow the graph along that the longer you've been awake, the higher that pressure is to actually fall asleep. So back to sleep architecture. Again, so we talk about the lighter stages of sleep, or stage 1 and stage 2. For many of us, stage 1 sleep is when we're beginning to fall asleep. And if somebody were to wake us up during stage 1 sleep, we might readily deny that we were even sleeping. So to all other observers, we certainly look sound asleep, but if somebody were to wake us up, we'd say, oh, I was just resting my eyes. I wasn't really asleep, because that's how we feel. We don't really feel as though we were actually falling asleep yet. That tends to last for most of us anywhere from just a very brief time frame to almost 10 minutes or so. And then we move into stage 2 sleep, where it takes a little bit more effort to wake us up. And then we'll go into stages 3 and 4, or what's called slow wave sleep. Now, slow wave sleep is identified on an EEG, or an electrical brainwave recording, and it's named that because when we fall into slow wave sleep, big slow waves appear, and that's the sign that our brains are really, really kind of winding down in these deeper stages of sleep. Those are the stages that when somebody tries to wake us up, it's difficult. It takes some effort, and we feel as though it's very, very hard to begin to wake up. And for the early stages of the evening, as we cycle through that, the slow wave sleep lasts anywhere from 20 to 40 minutes. And then after we go through those cycles, stage 1, 2, 3, and 4, then we jump into REM sleep, or we begin to have a dream. And initially, in the early stages of sleep, that dream cycle may last only a few minutes. And then throughout the evening, most of us cycle through these different stages from 1 to 4 into REM sleep, and then back into the deeper stages of sleep, and then back into REM, and so on and so forth. Each one of those cycles lasts for about 60 to 90 minutes, and then later on can last up to a couple of hours. And if you're aware, if you're really, really in tune to your body, and you're well aware of how long you're REM sleep cycle. There are some people get really, really good at this. They can actually identify that sleeping, for example, for 6 hours is going to be better because it's going to catch them at a typical end of an REM sleep cycle versus catching them right in the middle of deep wave sleep or slow wave sleep. And so they know that if they set their alarm for only 6 hours versus 6.5 hours, they're going to actually feel better despite having a little bit less sleep. Or if they set it for 7.5 hours versus 7 hours, they know they're going to actually feel better. So again, as you become very in tune to your whole sleep-wake cycles, sometimes you can begin to recognize those. As we get older, sometimes additional outside influences begin to make a big difference regarding our ability to actually get to sleep. And that can include some things like poor sleep hygiene. We try to do far too much and cram everything into the end of the day when that's the time that we should be attempting to really wind down and get ready for bed. Sometimes health issues can play a role, and that can be something as seemingly benign as a cold or an upper respiratory infection, but we've all had that episode where we can't breathe because we're so congested, and then we can't fall asleep because every time we try to fall asleep and then our mouth closes and then we can't breathe and then we wake up again, and it's just a miserable issue. Mood issues can play a big role in our ability to fall asleep. Being angry can make a difference in our ability to fall asleep, and there's that old wives' tale. You could think of it as our parents saying, "We'll never go to bed angry with somebody," but that can play a role if we're if we're holding on to some very intense emotions. That can make it very, very difficult to actually begin to get to sleep or to relax enough to fall asleep. Heading up to the top part of the left side of this graph, that spaghetti plate of letters, RLS, PLM, OSA, what the heck does that mean? Well, those are conditions that can very definitely impact your ability to get good restful sleep. RLS is restless leg syndrome, and we will talk about that more. We're going to talk about all of these more in depth. PLM stands for periodic limb movements, and OSA is our old friend, obstructive sleep apnea, which absolutely can play havoc on our ability to get good night's sleep. Poor time management kind of goes along with poor sleep hygiene in terms of, I'm just going to watch one more episode of the Great British Baking Show versus getting to bed early enough so that I feel good in the morning. And then cognitive issues as people age or develop conditions that might impact their brain's ability to think and reason appropriately can very definitely have some mixed up days and nights. And then finally, all of these conditions can contribute to some insomnia. So again, other sleep changes that occur as we age, sometimes we can develop a circadian rhythm shift. So I had talked about circadian rhythm just very briefly, and that's, again, the hormonal shift within our brain. Typically, this is driven by melatonin changes, and in nighttime hours, when it gets dark out, melatonin surges within our brain, and that causes us to feel sleepy, and then we want to go to bed and go to sleep and relax, and then we wake up in the morning and are exposed to bright light, and that dampens down melatonin production, and so then we're able to be awake through the day. Sometimes as we age, that melatonin surge occurs a little bit earlier, and so instead of really hitting a peak at 10 or 11 or so, it begins to hit a peak much earlier than that, and so people go to bed quite a bit earlier because they're sleepy, and then they wake up 8 hours later. But if you're going to bed at 7 or 8, well, 8 hours later from that is 3 or 4 in the morning. Patients have slept enough, or people have slept enough, but they say, well, I don't really want to be awake at 3 or 4 in the morning. What do I do? How do I sleep a longer period of time. And circadian rhythm shift can be addressed and treated. We need to treat it with bright light therapy and other issues. So if you feel as though circadian rhythm shift is something that you might be experiencing, it's absolutely something I would encourage you to speak to your doctor about. Gastroesophageal reflux disease can interfere with our ability to get good night's sleep, and sometimes as we get older, our risk of developing GERD is much greater, but so for those of you who don't remember what GERD is, that's just our old friend heartburn. And so if you've got some heartburn or indigestion, sometimes that discomfort can make it very, very difficult to sleep. Other medical conditions, Parkinson's disease, obstructive cardiopulmonary diseases, other issues can interfere with our ability to get comfortable in bed. So additional changes that we have to think about as we get older that are impacting our sleep is that our total sleep time decreases. So people who are older just tend to sleep a little bit less. Sometimes there's a little bit of an increase in sleep latency, or that time to fall asleep, but that's typically negligible. It's not something that normal people aren't going to experience an uptick from that 10 minutes that we had discussed previously to an hour or something like that. That's not what's happening with aging. If that is happening, then we have to look at a different cause. And then other changes that we have seen as we get older, those slow wave sleep stages and REM sleep begin to decrease just a little bit while stages 1 and 2 increase. Now, if there's something that's occurring that is making stages 3 and 4, those slow wave sleep stages, dramatically lessen, then that can impact our ability to stay awake the next day and really cause an issue with some daytime sedation. So let's talk about how dystonia and insomnia might go hand in hand. So sometimes they do and sometimes they don't. So we're going to look at two different conditions here. The first is primary insomnia. That means that before you ever developed any symptoms of dystonia, you had insomnia or you had problems with sleeping. And if that's the case, then your dystonia certainly might make things a little bit worse, but it probably wasn't the cause of why you're not sleeping. But unfortunately, if we do have dystonia, then sometimes we are going to be at a higher risk of developing sleep problems or insomnia as well. And the frustrating part about that, as we'll talk a little bit more about, though the insomnia might not get better even as we're treating the dystonia. So why do we have sleep problems because of dystonia? Well, bottom line, we don't really know. But we do know that there is, in some cases, a bit of a correlation with the severity of your dystonia. So if you have blepharospasm or if you have an oromandibular dystonia, then it is very likely that the more severe your symptoms are, the more likely you are to have a sleep disturbance, and the more likely that sleep disturbance is to be more severe based on how severe your symptoms are. But if you have a focal dystonia, including a cervical dystonia, there doesn't seem to be a significant correlation. You can have a really, really severe cervical dystonia, and you may not have any significant sleep problems whatsoever. You can have a really severe focal dystonia or even a generalized dystonia, and that may not impact your sleep issues. We can see that sleep problems are identified even in patients whose dystonia is under terrific control, whether that is with oral medications or botulinum toxin injections or even deep brain stimulation. And we know that in most cases, dystonia goes away when people sleep. But nonetheless, people can still have issues with sleep problems. And, then there's the final observation, and that is that the dystonia itself might make it more difficult to actually just get comfortable in bed so that you can, in fact, go to sleep, let alone what's happening when you finally do get to sleep. So Some sources would suggest that more than 60% of patients with dystonia have excessive daytime sedation or daytime fatigue. That's a big number, and it's certainly something that we can't ignore. And we do know, as I've just mentioned, that sleep quality can be diminished in patients that have not just cervical dystonia, but all dystonias. And I've already mentioned that sleep quality and excessive daytime fatigue and daytime sedation don't really seem to get a whole lot better, even in patients whose dystonia is really, really well controlled. The last thing that we need to kind of peek at here for just a moment is that when we have significant daytime sedation and we have poor sleep quality, more people can develop some significant mood issues, including depression or anxiety. And so there's a lot of different reasons for that. But if you are having some significant mood issues, you might want to begin to look at the quality of your sleep, because the two can certainly go hand in hand. And so when we talk about mood issues, so it's kind of a bit of a vicious cycle. Not only can sleep issues lead to mood disturbances, but mood disturbances can contribute to exacerbation of sleep issues. When we have anxiety, we might have some worry. We may ruminate about different things. It may be very difficult to get to sleep. When we have depression, it might be very, very difficult to get to sleep or stay asleep. We might wake up far too early, or things just feel hopeless and helpless. Both depression and anxiety can occur preceding dystonia or subsequent to dystonia, and so we need to make sure that we have a good recognition of where these mood disturbances might have occurred in our cycle of being diagnosed and treated. But we have to keep in mind that there are many different medications that are very effective in treating these. Now, this is not a medication lecture specifically for mood issues, so I'm not going to go into those right now. But if you feel that mood issues are a significant problem, I would encourage you to talk with your primary care doctor about getting some evaluation and treatment for that. So now, based on that, we have to keep in mind that sometimes medications that we're taking might actually worsen some insomnia, and that can include certain antidepressants. Some antidepressants can be very activating, and others can be very sedating. And so sometimes we can use that to our advantage. So if you're on a medication that is sedating, take it before you go to bed. Correspondingly, if you're on a medication that is activating for you, try to take it in the morning so that you're more awake and you can utilize that energy during the day that you need to. Now, the other thing to keep in mind regarding medications is that while common side effects are common, everybody experiences a little bit of a different reaction. And so your doctor might say, well, I'm going to give you this medication because it's going to help you sleep. And you take it and you feel more kind of revved up and activated. You may be one of those individuals for whom it's in fact not sedating, but has the opposite effect, and that's okay. That doesn't mean that your system is broken. It just means that you're a unique individual. Other medications can lead to insomnia, especially medications for lung disorders, COPD or emphysema. And we talk about using coffee or smoking cigarettes or drinking alcohol, but all of those things can impact our ability to sleep well. And we kind of forget about those because they're so ubiquitous or common in our society. If we're going to drink coffee, and I'm not going to tell you not to because I do every day, and it certainly can be very beneficial, but if we're going to drink coffee and we have problems sleeping, then we're going to want to cut that coffee off at like 1 or 2 in the evening, or in the afternoon rather, because I think most of us lose sight of the fact that coffee doesn't take effect immediately in terms of the impact of caffeine, but that caffeine effect can hit us really at its peak, sometimes several hours later, 4, 6, or even 8 hours later for some individuals. And so if you're drinking coffee at 4 or 6 in the evening, then you can see that as you're trying to wind down and get to sleep, you may really have some significant problems. Tobacco and nicotine in tobacco can be just as activating for many individuals. And again, I think that we often lose sight of that because it can be so very commonly seen in our society. Alcohol is often viewed as a depressant, but we lose sight of the fact that while it might make us fall asleep right away, it really does impact our ability to get into those deeper stages 3 and 4 sleep and actually get good quality of sleep. And so while alcohol might power us down pretty rapidly, the good deep wave sleep and stages 3 and 4 sleep that we get is much less. So this is just a little cartoon talking about many of us. How well do I sleep? Well, at work, I sleep really, really well. When I'm watching a movie, I sleep really, really well. When I'm driving, hopefully you're not falling asleep. Laying in my own bed at night, ding, we're wide awake, thinking about everything that we need to get done. So let's talk again about primary insomnia, which is insomnia that has occurred before you were ever diagnosed with dystonia. And what is insomnia? We use that quite a bit, but it's an inability to get to sleep. It's an inability to stay asleep. It's an inability to sleep through the night. It is fragmented sleep, and we have problems the next day because of those issues. So acute insomnia is insomnia that has lasted for less than 4 weeks and is often associated with a stressful situation or an acute illness, but then after that external issue has resolved, our insomnia goes away. In acute stages, sleep medicines can be very beneficial. In chronic insomnia cases, those are individuals who have had problems falling asleep for well over a month, and in many cases for many months or years. And in frequent cases, it's kind of a bit of a learned behavior. More than 60% of the time, there's some underlying psychologic factors that actually are impeding our ability to get a good night's sleep. And in those cases, frequently we'll see that behavioral therapy, cognitive behavioral therapy, learning to relax, can actually be far more beneficial than medications. And if you read the labels on sleep medications, very often they'll say, this is not to be used for more than X period of time, where X period of time is, in the majority of cases, a fairly short time frame, about 8 weeks or so. Primary insomnia, again, is insomnia that has been around for a long time for many patients, often not easy to treat, but is treatable. So when we talk about why people might develop issues with insomnia, maybe it's genetic. Maybe there was some early adverse experience that you were exposed to that decreases your desire to want to go to sleep. Or there's a stressful trigger. So something happened, medical, behavioral, something within your environment that caused some stress, and then we developed, because of that, some poor sleep hygiene, some more arousal type issues, some catastrophic thoughts or worry as we were trying to get to sleep, and then that can all lead to chronic insomnia. And it's a bit of a cycle as we go through. And this is a similar type of a thing in a different type of a graph that, we develop some transient insomnia, we get frustrated, that delayed sleep onset disrupts our ability to get to sleep. We begin to worry about how we're going to function the very next day, and then that cycle becomes chronic, and keeps going and going despite the fact that the original stressor is long gone. And that's what we call a chronic or a learned insomnia. So how do we treat a chronic insomnia? Well, we talk about great sleep hygiene. And so what is that? That's not showering before you go to bed, okay? That's not sleeping in the bathtub. So we're talking about things like setting up a ritual for yourself to begin to relax and to get to sleep. We talk about avoiding coffee and alcohol because that can absolutely impede our ability to get to sleep. We save our bed for sleep and for sexual intercourse. But otherwise, we're in bed and we're only sleeping. Maybe a light snack before we go to bed, not a big heavy meal. Our room is quiet, it's cool, it's comfortable, and it's dark. We don't have a television going on. Regular sleep hours become very important. Exercise earlier in the day is very important. Exercise too late in the day can have an activating response for many individuals. And so if you're trying to get some good exercise in, doing that right before you try to go to sleep, often not a great idea. Avoidance of napping if we have problems with insomnia. Time and again, we have identified that people who have insomnia do nap during the day because they feel lousy. They're tired. They want to have some semblance of normality, and so they take a nap. But we know that very often naps that are stretched out more than 20 or 30 minutes during the afternoon or during the course of the day can absolutely impede our ability to get to sleep the following night. So part of that ritualistic behavior in terms of setting up to get to sleep, go to bed when you're ready to sleep. When you're in bed, make sure that you're sleeping the majority of the time. If you're in bed and you're awake for more than 20 minutes, get out of bed. Don't just lay there thinking how miserable you are. So again, we talk about simple bedroom furniture. We don't want things to be too frou-frou-y because that can disrupt our ability to really relax. And keep things in proper perspective. So 1 or 2 nights of poor sleep isn't the end of the world, and we can't catastrophize things. So if you get good sleep more than 70 to 75% of the time, you're actually doing really quite well, and we have to keep that in mind. So again, this is not a lecture about medications. So there are many medications which are frequently used to address chronic insomnia, but those aren't necessarily the best long-term option. And so again, I would emphasize, please speak with your primary physician about any medications which you might want to consider using occasionally to address issues with insomnia, but not something that you're going to utilize every single night. So hand in hand with insomnia, we have issues with daytime sleepiness. So if you have insomnia because of your dystonia, you're sleep deprived because of your underlying condition, you might be sleepy the next day. Unfortunately, many of the medications that we use to treat dystonia fall under the class of muscle relaxants, which very frequently can lead to sleepiness. Just because you have dystonia, you're not immune from developing issues with sleep apnea. And interestingly, many people with dystonia are at risk or more likely to develop issues with restless leg syndrome. Associated with restless leg syndrome are periodic limb movement disorder, periodic leg movement disorder, and both of those together can contribute to issues with daytime sleepiness. Other medications that can contribute to daytime sleepiness, anti-anxiety medications, and on that list, commonly used alprazolam or Xanax and clonazepam. And we have to keep in mind that clonazepam is also falling under that category of the muscle relaxants. And there are just a few listed here, but there are many, many that can contribute to daytime sleepiness. Pain medications can very frequently lead to sleepiness in the day. We think about CBD and CBD oil as a great medication or a great substance for relaxation or pain control, but for many individuals it can lead to sleepiness as well. Seizure medications are sometimes used for pain control and can often be associated with daytime sleepiness, and other medications certainly. There's a whole host of them that can contribute to issues with daytime sedation. Let's take a little bit of a detour talking about restless leg syndrome. So this is interesting because restless leg syndrome can affect up to 10% of the population, which is actually quite a bit more than dystonia. And it is often familial, which means it's passed down from generation to generation. It's a sense of a creepy, crawly feeling in your legs as you're attempting to relax, whether that's sitting in a chair or laying in bed. And after moving your legs, the feeling goes away until you try to relax again for a period of time, and then it comes back. Sometimes it can be associated with iron deficiency. It can be associated with anemia. Women who are pregnant can develop restless leg syndrome. Restless leg syndrome can be identified or seen frequently in patients that have chronic renal failure. Many medications can make restless leg syndrome worse, including many antidepressants that fall into the category of selective serotonin reuptake inhibitors, or SSRIs. Certain antihistamines can make restless leg syndrome worse. And so if it is something that you feel you're experiencing, certainly to ask your doctor for a couple of simple blood tests to make sure there's not anything that needs to be addressed or that could be reversed is reasonable to do. And there are many medications that can be used to treat restless leg syndrome. So we diagnose it by history. If we think that you've got periodic limb movement, that's actually a kicking, not just a sensation, but a kicking in your legs. And we diagnose that with a sleep study. That's how we prove that. And treatments for restless leg and periodic limb movement do overlap. We use medications that are frequently used to treat Parkinson's disease. So dopamine agonists, including pramipexole, ropinirole, rotigotine. Sometimes we can use gabapentin, especially long-acting gabapentin. There are other medications that can be used to help treat these conditions as well. If you have dopa-responsive dystonia or levodopa-responsive dystonia, our old friend Sinemet, or carbidopa-levodopa, is a very potent treatment for restless leg syndrome. There's a little cartoon here. Man's talking to his wife. Doctor found out why I snore so loudly. I have obstructive sleep apnea. And his wife says, so in English, that's inner neck fat. I prefer the way he put it. So let's talk a little bit about sleep apnea. So much like restless leg syndrome, sleep apnea far more commonly seen than dystonia. Up to 5% of the population can be impacted. Sometimes there's a familial history as well, and if we are heavier, our risk of developing sleep apnea goes up much higher. As we get older, or if we're male, the risk of sleep apnea is higher as well. Sleep apnea can be seen in kids, and so if you have a child who snores, you might want to check them out, make sure they don't have enlarged tonsils or enlarged adenoids, because that can contribute to sleep apnea in children. And interestingly enough, untreated sleep apnea in children can look a lot like attention deficit disorder. So if you have a very small jaw and a big neck, just anatomically, you may be more at risk of developing sleep apnea. If you're a smoker, if you drink alcohol, if you take medications that are going to cause you to be sleepy, or if you just are allergic and have a lot of congestion, you're going to be more at risk of having sleep apnea. Now, sleep apnea is more than just really loud snoring. It's actually stopping sleeping stopping breathing while we are sleeping. We actually just cut out breathing, and that can decrease oxygen to our brain, and that can lead to all sorts of problems. So consequences of sleep apnea. So there's snorting, gasping, stopped breathing during the night, and then during the day, because that really disrupts our sleep cycles, we're sleepy, we're tired, we're irritable. And we can see that that actually can lead to some memory problems. People who have sleep apnea, especially untreated sleep apnea, are more likely to develop issues with accidents, including car crashes. There is higher death rate seen in people who have untreated sleep apnea. Other considerations, people who have untreated sleep apnea are far more likely to develop congestive heart failure or high blood pressure. That can lead to heart attack, stroke, other cardiac arrhythmias. And when we don't sleep well, that changes hormonal fluctuations within our body, especially stress hormones, and then that can lead to escalation of weight gain, which in turn can lead to increased risk of conditions like diabetes. So sleep apnea is not just a benign, oh, you snore loudly type of a condition. It is absolutely something that can have some significantly serious consequences. And so if your doctor talks to you about sleep apnea, please don't try to negate it or think that it's something that is really not very important, because it can be extremely important. How do we treat sleep apnea? The most common certainly is CPAP, which is a mask which is put on that blows air into your lungs. You can actually get oxygen as you're sleeping, keeps your airway open. Continuous positive airway pressure is what CPAP stands for. And more than 70% of individuals ultimately adapt really, really well to treatment of sleep apnea. If you're one of the ones that don't, there are other treatment options that may work well for you. And sometimes it's a matter of weight loss, sometimes a bite splint or a dental appliance, but I would be very cautious if you're seeking out something like that, because you want to work with somebody that has some expertise in this area. So in summary, sleep apnea, very, very common, but can have some significant consequences, very easily diagnosed and treated. And the benefits are that if you have sleep apnea and you treat it, you're going to feel a whole lot better the next day. We have seen time and again that when patients with neurologic conditions, including dystonia, sleep better, very often their neurologic condition is better controlled the next day, and we have less sleepiness, less fatigue, we're less at risk of all of those other issues that we had discussed. And so if we're talking about just not being able to get some good sleep, we always have to at least hit upon some good sleep hygiene, some basics for good sleep hygiene. And so we had touched upon this briefly. We want to make sure that we have regular times for sleeping and waking. If you have any kind of a smartphone now and you use your smartphone as an alarm, very often it'll tell you, set a regular time to go to bed, set a regular time to wake up, and having that pattern will really make a difference for your ability to get to sleep and then wake up the next day. A lot of these I've already discussed. Maintain your bedroom. It's dark. We don't want to be watching television in bed. That's one of the worst things that we can do. We want to avoid napping, especially later in the day. Prudent exercise and eating. That means exercising earlier in the day, eating a minimal amount right before we go to bed, and just things like avoiding stressful situations right as we are going to sleep. Other ways to battle insomnia, if you're not quite ready to go to see your doctor about this, then you can maybe listen to a soothing story. You can practice meditation, which is kind of a focused way to really relax. There are many podcasts. If this lecture series itself isn't helping you get to sleep, then there are other podcasts that can help that are available either on Apple or on Android. And I've listed just a few of them here. Several of them are free. but they are different stories or other things that can help you fall asleep. We were laughing about the IKEA Sleep podcast. That's actually IKEA staffers that are just reading the names of different products from the IKEA catalog that can help you get to sleep. So let's not forget the caretakers. So anybody that takes care of somebody that has a chronic ailment often have so many mood issues associated with that because it's difficult to be a caregiver, and caregiver burnout and stress are very real, and we cannot lose sight of that. The comment, take care of yourself, keep yourself intact. Let's be on an airplane, place your own oxygen mask first. Cliched, but very, very true. We cannot take care of anybody else if we ourselves are exhausted or burned out. And we have to keep in mind that caring for somebody else is hard, and it's okay to ask for help. There are so many different factors that go into caring for somebody else, whether that is concern about how you're going to continue to care for them, what's happening with financial situations, what's happening with the need to adapt the house, or any other consideration. So we know that that all piles on, and that can impact you as a caregiver and your ability to get to sleep. And so making sure that you have your way to relax, your way to escape, your way to get away, to recharge is very, very important. So in conclusion, and I think that I hope we're going to have at least a few questions based on this, but in conclusion, insomnia, sleep disturbance, very, very common in people with dystonia. And there are many, many different treatment options that are available. Keep working until you find the best option for you, and don't ever give up hope as we work toward the best treatment option for you. And then finally, Robert Frost and his comment, the woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. Well, hopefully everybody listening doesn't really have miles to go before you sleep, but an ability to recognize that a good night's sleep is an absolute attainable goal. So thank you for your attention.
Thank you, Dr. Taylor. That was great. And we do have a number of questions, so I'm going to tee them up right now. You touched on meditation and some behavioral therapies to sort of help learn good sleep hygiene and help you relax and that kind of thing. We have a question from somebody, just the concern about the number of medications that they're on for their dystonia. Are there herbal remedies that they might consider? They're just, not wanting to add one more medication to their list that they're taking every day. And if there are herbal remedies, what advice do you have about making sure that, they talk with their doctor about what they're doing around that?
Well, certainly, that's a great question, and especially if you're on a laundry list of medications, whether it's for dystonia or dystonia and other medical conditions, it's a good thing to keep in mind, and that is how might anything that I'm adding as a supplement have it, interact with my current medications. Melatonin typically does not interact with other medications. Keep in mind, melatonin is created by our brain, and when we are taking over-the-counter melatonin, we're just supplementing the melatonin that our brain is making in an effort to help bump up those levels to feel sleepier as we are trying to go to bed. Melatonin is not a quote-unquote sleeping pill. It's not going to knock you out. It's not going to make you go to sleep immediately. So we recommend that if somebody's going to use that, they take that, an hour or two before they actually want to go to bed, and then use that time in between to go through your various relaxation rituals to help the melatonin really work at its best. Other herbal type things, chamomile tea is, again, kind of a cliched type of an approach to relaxation, but can be very beneficial for many individuals. Valerian root is one that we're starting to see might or might not have some interaction, but again, that's available in various tea forms. I would stay away from kava. Kava can very frequently be associated with significant drug-drug interactions and even some liver problems for many patients. And another one, it touched upon CBD oil. We're learning now that CBD oil can actually cause some metabolic changes in other prescription medications. And so if that is something that you are interested in using, make sure that you talk to your physicians about it, because that can have some ramifications that may not have otherwise been recognized.
Mm-hmm. Can you, we had a couple of people comment on the kinds of things that they do, like you were mentioning the podcasts and people listening to, background sort of white noise, ocean waves or rain and that kind of thing they found helpful in helping them just to sort of relax as well. Could you comment on what we know about the relationship between persistent pain and trouble sleeping?
So I guess when you say persistent pain, I'm going to assume that means chronic pain. Well, chronic pain is a stress. It's one of the most potent stressors that we see, and we recognize frequently that stressors are going to impact our ability to get to sleep. And so if we have chronic pain, that just by nature of it, just what it is and what it does is going to act as a stressor and it's going to impact us. So unfortunately, that can play a role. Now, there are many ways to help control pain, not necessarily medication, but so again, that's something that I would encourage you to work with your doctor regarding to try to address, how do you dampen down any chronic pain so that it's going to have the least impact on medication as possible, or at least impact on your ability to sleep as possible.
Sure. And then we have a couple questions from people who have cervical dystonia, and one who has a fairly significant head tremor and finds it difficult when just going to bed and placing the head on the pillow, just sort of trying to stop, calm that all down in order to work on falling asleep. Do you have any suggestions on what they might try?
That's interesting, and I don't know if that individual has identified a sensory trick that can help diminish the tremor as they're laying flat, or sometimes changing positions in bed. Sometimes a matter of just, changing, pillows, finding, different cervical pillow, having your shoulders elevated a little bit, and so you're not laying flat with just your head on a pillow, but sometimes having a wedge so that your upper body is propped up just maybe 15 to 30 degrees can sometimes change the trajectory of the tremor enough so it's not quite as disturbing. The downside is that there's not a one-size-fits-all. I do hear the complaint that of head tremor associated with cervical dystonia impacting ability to fall asleep frequently. If you're a patient that is getting botulinum and toxin injections, sometimes there are some additional kind of tremor-generating muscles that we can include in the muscles that we're targeting that can really be beneficial to help diminish that tremor. Or sometimes there's medications that can help diminish tremor.
Okay, so they should speak with their doctor and specific. Yeah. So we have a couple questions about dreaming and specifically nightmares. What do we know about what causes nightmares? And one person actually noted that they have nightmares on a regular basis and actually feel like when they wake up they're exhausted.
So that's interesting. We don't really know why people develop nightmares. It's kind of along those REM sleep issues. For people who have nightmares, they seem to be a little bit more in tune to recognizing their dreams. And yes, if you are waking up and you're frightened because of what was happening within the dream itself, that can be exhausting, because then that can make it more difficult to get back to sleep, and that's certainly a disrupted night of sleep and fragmented nights of sleep, which can make a big difference regarding how good you feel the next day. Sometimes medications that we take can impact our dreams and lead to some nightmares. So that might be something you'd want to talk to your doctor about regarding trying to make a difference. Now, one statement that I've discussed with people, and this is really more anecdotal than medical, so I hope it's appropriate to bring up here, but in the context of dreams, I think kind of anything goes. And that is, for many of us, we have the capability of what we call lucid dreaming, meaning when you're in the middle of a dream, whether it's a good dream or a nightmare, we can control it. And we can say, I'm dreaming here, and I don't want whatever is happening in my nightmare to continue. I want to change it. And so whether it's I can't find my way out of this house, or something's chasing me, whatever your nightmare is, very frequently you have that ability to change that and make the dream less problematic. And sometimes it's just telling yourself as you're going to sleep that you're not going to have a nightmare that night. And that sounds kind of, almost voodoo-ish or a little bit out there. But our brains are very attuned to those types of suggestions. And so if you are having nightmares repeatedly, working with somebody to help you through those types of different ways to address that can be very beneficial.
Mm-hmm. That's good advice. You talked a little bit about taking a look at the medications that you're taking, and if there's the opportunity to take those that make you sleepy, changing the sequence or the order in which you take them during the day. A question about, I think especially as people get older, they're on different medications prescribed by different doctors. So do you have advice on how people might approach that whole discussion about, is there flexibility around my medication schedule?
Yeah, and I tell this to every person that I speak with, and that is you should always know every medication that you're taking and the reason why you are taking that specific medication. And every doctor that you go to should have a complete list of the medications that you're taking. And along those lines are, if any doctor wants to prescribe a new medication, it is absolutely appropriate, and you should do this, and that is to say, is this going to interfere with anything that I'm already on? And, how is this going to impact me? How is this going to change the complexity of how I'm taking my medications? And so it's important to absolutely have that discussion every time you see your doctor, and to say, okay, you want me to take this blood pressure medication 3 times a day, but every time I take it, it knocks me out. Is there a different version of this? Is there a different way I could take it? Do I have to take it 3 times a day? Could I get away with taking it twice a day? To ask all of those questions, to have that open dialogue is absolutely important. And I always tell everybody, and I tell people that come to see me the same thing. If you can't have this discussion with your doctor, find another doctor, because your doctor should be willing to answer these questions, or at least have somebody in their office who can answer these questions for you.
Yeah, I think that's really important. So, we unfortunately our time has come to an end, and we've got a number of other questions that again we'll look to put some information in the dialogue and get answers out to these. But I want to thank you, Dr. Taylor, for the presentation tonight and for helping us better understand dystonia and its relationship to sleep, and just how important sleep is overall. So thank you so much for your presentation tonight. We really appreciate it.
Thank you for having me, and thank you again to everybody who was part of the program tonight.
Yeah.
Good night,
thank you, everyone. Good night.